Hi, and welcome to today's cardiac adventure. Today, we're going to talk about mitral valve regurgitation. So stay tuned, subscribe, and let's explore the hemodynamic changes, symptoms, diagnosis, and treatment options for this condition. Alright, so in mitral valve regurgitation, there is a retrograde flow of blood from the left ventricle into the left atrium as a result of an incompetent or ineffective closure of the mitral valve. Now, if the valves are fine, then certainly you would expect blood to flow in the forward direction into the aorta during ventricular systole. But in this case, blood flows into the aorta as well as into the left atria. And so we're going to call this regurgitant volume. Now, at any point, there is also blood coming from the pulmonary veins. And so we could actually deduct and say that there is excessive amount of blood that is being delivered into the left ventricle during diastole. And so we could express this as an increase in the left ventricular and diastolic volume. All right. So with time, or a very fundamental or key word is left ventricular volume overload. This is very important. And so the volume overload becomes significant with time. What is the effect? This is going to lead to possible left ventricular failure with a decline in ventricular contraction as well as a decline in the ejection fraction. So, an important thing to understand is that despite all that has been explained, chronic mitral regurgitation is often well tolerated in its early stages. But with time, as the ventricles dilate, it dilates together with the annulus. Okay, and so once the annulus dilates, then it is also opening the orifice of the mitral valve. It is rather worsening the mitral incompetence. And so this is going to lead to a more regurgitant flow into the left atria. Now, again, it's important to understand that blood pressure is a determinant for the regurgitant volume. And so if you treat the blood pressure, then you could actually somehow reduce the regurgitant volume and decrease the progression of the disease. So, an important note in this case is that in the chronic mitral regurgitation state, the left atria is able to accommodate the regurgitant volume. Okay. But if this continues for a while, then the volume in the left ventricles will certainly be transmitted to the left atria. And so the atria is doing that because it is trying to push a lot of fluids or blood into the left ventricle. So there's going to be a left atrial enlargement. Now, that enlargement would lead to some architectural changes. And so electrical conductance through that enlarged atria will take time. And so this can be seen as a broadened P wave on the electrocardiogram. So a left atrial enlargement would also lead to atrial arrhythmias like atrial fibrillations. And this two put together is a risk factor for the formation of systemic embolism, which is a very important thing to also note in the management of mitral regurgitation. So it's important that at some point there's going to be a left atrial enlargement and atrial arrhythmias and even systemic embolism. And I would like to say that pulmonary congestion, and the right heart failure are usually very late findings in chronic mitral regurgitation. But if this continues for a while and it is not treated, then certainly patients can have pulmonary congestion. So in the end, this leads to symptoms of right and the left heart failure. Now, in contrast, acute mitral regurgitation, such as that which occurs as in papillary muscle rupture, okay, this would lead to a rapid increase in the left atrial pressures because it's an acute process. And so the left atrium is not ready, it's not compliant and all of a sudden there is a regurgitant flow into that compartment. And so this will lead to a rapid increase in the left atrial pressure, and this will cause pulmonary congestion quickly, and even it can evolve into a shock. So that's a difference. But in the chronic state, it is compliant and it is able to accommodate the fluid gradually. So that's an important thing to say. And so the apex beat may be displaced, and you may also feel a heave when you palpate the chest. On auscultation, mitral valve regurgitation presents with a soft S1 sound. Now you recall that S1 represents mitral valve closure. So there is actually a diminished coaptation of the leaflets. The mitral valve leaflets are somehow wide apart. They are not aligned properly. And so during closure, you would not expect to have a loud but a rather soft S1 sound, which is then followed by a harsh pansystolic murmur at the apex, which radiates to the axilla because a portion of the blood is released into the left atrium during systole. There may also be a split in S2. You recall S2 has the A2 component, which is aortic valve closure, and the P2 component, which is the pulmonary valve closure. So in severe mitral regurgitation, the pulmonary valves may take time to close, and that can split or move the P2 component slightly wide, causing a split. All right, so the symptoms of chronic mitral regurgitation can be quite varied, ranging from asymptomatic to more severe symptoms of left ventricular failure, that is an exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea. There may be signs of atrial fibrillation, chest pain, infective endocarditis. In more advanced cases, pulmonary congestion and right heart failure may develop, and aside the shortness of breath, this may also present with an elevated jugular venous pressure, peripheral edema, hepatomegaly, or even ascites. So in the investigations, an electrocardiogram, which is non-specific, may reveal signs of atrial fibrillation, left atrial enlargement, and a right ventricular hypertrophy. Complementing the electrocardiographic findings, an electrocardiogram is the crucial and the primary diagnostic modality that provides valuable information on cardiac structures and function. So both transthoracic and transesophageal echocardiography offer insight into the effective regurgitation orifice area. I'm about to talk about this in the next slide. The regurgitant volume and fraction, and it also helps assess the leaflet thickness, its mobility, calcifications, and vegetations. Furthermore, echocardiogram can also identify left atrial enlargement, a common feature in this condition, providing a comprehensive understanding of the cardiac status. Now, here we are looking at some very important echocardiographic parameters. And as you recall, in mitral regurgitation, there is a backflow of blood from the left ventricle into the left atrium, right? And so there is a point in the left ventricle where blood flow converges before entering the mitral valve. And as you can see right there, this part is going to be called the area of flow convergence. This part is otherwise known as the proximal isovelocity surface area. All right. Meanwhile, the vena contracta, you can see right there, vena contracta is the narrowest stream of blood that flows through the valve immediately after the valvular orifice. Okay, and the regurgitant fraction is the ratio of the regurgitant volume to the forward stroke, and this is often expressed as a percentage. And the effective regurgitant orifice area is often deducted from a formula. And so regarding vena contracta, if it is right there, you can see if it is less than 0.3 centimeters, then it is considered a mild regurgitation. If it is more than 0.7, it is considered severe. Again, when you look at the regurgitant fraction, right, it somehow correlates with the regurgitant volume per beat. And so if the regurgitant fraction, that is the amount that comes here, okay, is less than 30%, and the volume that also comes there is less than 30 mL, then you can say that it is what? It is a mild regurgitation. And if the fraction is greater than 50% and the volume is greater than 60 mils, then this is considered a severe regurgitation. And regarding the effective regurgitant orifice area, if it is less than zero point 0.2 square centimeter, it is mild. And if it is greater than zero point 0.4 square centimeter, it is considered a severe regurgitation. So the important thing as a clinician is to remember that you don't want to miss a left ventricular dysfunction. And so you would like to repeat the echocardiography at least every 6 to 12 months if the patient has some symptoms, right? And you can refer to the surgical department for, say, a valvular repair or a valve replacement. So a chest x-ray may reveal the presence of cardiomegaly along with left atrial enlargement, which may show the double density sign. In advanced cases, x-ray may also display signs of pulmonary congestion. When non-invasive diagnostic modalities are inconclusive, cardiac catheterization can also be employed to provide further clarification. For example, it allows for evaluation of the coronary arteries, cardiac chambers, as well as the pulmonary wedge pressures. Other modalities such as cardiac MRI and stress echo may also provide some value. Management, and as already mentioned, chronic mitral regurgitation is often masked in its early stages, and so it requires careful monitoring to prevent the development of left ventricular dysfunction. Treatment goals include delaying disease progression and preserving cardiac function. So, vasodilators such as AC inhibitors and ARBs are commonly used to control blood pressure, which is also a crucial determinant of the regurgitant volume. So, by reducing the regurgitant volume and the left ventricular dilation, these medications may probably help slow disease progression. Additionally, diuretics may also be employed to alleviate pulmonary congestion and decrease preload. The management of atrial fibrillation often involves rate controlling agents such as beta blockers, non dihydropyridine calcium channel blockers, and digoxin. In cases of hemodynamic instability, a synchronized DC cardioversion may be necessary and should be accompanied by an adequate anticoagulation for 2 to 3 weeks prior to the procedure. Alternatively, a transesophageal echocardiography to minimize the risk of systemic embolization. This also applies to pharmacological cardioversion, for example, as with amiodarone. So, anticoagulation is crucial for patients with valvular atrial fibrillation, and this is preferably done with warfarin. Additionally, prophylactic measures include antibiotics for recurrent rheumatic heart disease and prophylaxis against infective endocarditis. So, surgical management of mitral valve regurgitation typically involves valve repair or replacement to alleviate symptoms and improve heart function. According to some studies, valvular repair has been shown to be a highly effective treatment option, offering a similar outcome to valve replacement. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.